I'm very happy to have to be able to introduce to you Dr. Alan Eunice, who will be our speaker this afternoon. And just a few words about Dr. Alan Eunice, who, by the way, is our new Medical Director for Youth Services here at Kootenai Behavioral Health Center, and we're just thrilled to have him here. Dr. Eunice, he completed his undergraduate education at Dartmouth College. Later, he attended the University of Pittsburgh, where he achieved his medical degree, and then later on at the University of Pittsburgh completed his residency in child and adolescent psychiatry. He is boarded in both general psychiatry and child and adolescent psychiatry. After that, he went on to the University of Utah, where he completed neuropharmacology training at the University of Utah, and that was in 1987. Later, he went to the University of Washington, where he served as the medical director of the Children's Inpatient Psychiatry Unit at Children's Hospital and Regional Medical Center in Seattle, and that was in 1987 to 1994. Notice I didn't give you the early dates. He subsequently received a Physician Scientist Development Award and opened the Developmental Neuropsychiatry Clinic at the Center for Human Development and Disability at the University of Washington in 1998 and worked in that position through 2001. Later, he joined Johnson & Johnson Pharmaceutical Research and Development, where he served as project physician on a number of drug development projects, including Topamax Psychiatry and Risperidol Pediatric Exclusivity. He returned to the state of Washington in 2003, accepting a position as staff physician at Sacred Heart Medical Center, and later became their medical director of psychiatry in 2004. This year, he joined Kootenai Medical Center, and as I spoke to before, is our medical director of youth services here at Kootenai Behavioral Health. I am so pleased to have Dr. Eunice come and speak to us on this topic, early onset of affective disorders. Thank you, Dr. Eunice.
Thank you very much.
Let's welcome him.
Okay, so once you fill out those evaluation forms, you're supposed to turn them in to me so that I can kind of go through them and pull out any of the ones that I don't want to pass on. So, first, just a few words about myself. Just in terms of disclaimers, you all should know that I do speak on behalf of a number of pharmaceutical companies. I'm a speaker for the Lilly Lecture Bureau. I also speak on behalf of Janssen and McNeil. So I do a lot of promotional talks on behalf of the product sponsors that have been developed by those companies. But what we have today is a CME activity. These are my own slides. I developed them myself. I hope to include some data, but I don't want this to be seen as a promotional talk of any particular product. So I hope you all appreciate that. What I intend to do is cover the issue of early onset mood disorders. Now, obviously, to do this, as many of you know, mood disorders have their own kind of developmental trajectory. And so what I would like to do today is talk about depression after we finish a discussion of depression, which in fact is usually the most common early onset mood disorder. We then will move into bipolar disorder and talk a little bit about suicide. Throughout the talk, I will have discussions about antidepressants and other pharmacologic strategies that are used to treat young people with mood disorders. And I certainly do not want to ignore the other psychosocial treatments and some of the issues regarding long-term management of mood disorders. One of the things that I find so exciting about the world we live in now is that mood disorders really represent a potentially curable psychiatric illness. The data that has gradually accrued over the past few decades since I got my credentials in child and adolescent psychiatry is that early and effective treatment to the point of remission mitigates the course in the long run, so that the better you treat the first episode of depression, the better you treat the first episode of mania or mixed state, the more likely that developmental trajectory be more benign. So this is if you walk away from this lecture with anything, just know that. And I know many of you work in the area of mental health. Many of you work with other patients who suffer from depression or other mood disorders. These are potentially curable conditions. And almost 2/3 of people who present with their first episode of depression will never have another episode if properly managed. Okay? So I know that it's hard to believe, but that's where we are right now in the state of the science. So now I want to digress a little bit as well and talk about, obviously, in no way do I mean to promote, I can't promote the use of medicines in kids, especially in those situations where there isn't FDA approval. On the other hand, we have to acknowledge that mood disorders affect the young, and in fact, a lot of the young. Obviously, mood disorders in children has been estimated to occur in 2 in every 100 kids of elementary school age, and 4 to 8% of adolescents. So this is not an insignificant medical problem. Children with depression are greater risk for suicide, poor academic outcomes, problems with alcohol and illicit drugs, and then troubled relationships with their families and their peers. Psychotherapy has been the traditional mainstay of creating remission in mood disorders. The medicines that we frequently use, whether on-label or off-label, merely address symptoms. The real rehabilitation that occurs in an individual with a mood disorder occurs in the context of long-term psychotherapy. So I can't say that enough either, because, and both are important. The medicines that we prescribe put kids into, if you will, a biological space where they have the energy, the attention, the decreased anxiety, so that they can do the work. But when an individual has been depressed for any period of time, there's a great deal of injury that's been done, not just to the brain, but also to the mind, to the way that person approaches their life. It's very important that we as professionals work hand in glove, that we're thoughtful in our use of medicines, but that we don't use medicines instead of, because that's inadequate treatment. Just to give you a sense of the number of children with chronic medical and chronic health conditions that actually limit their activity in the United States. These are data from the Centers for Disease Control, 2001 to 2002, so it's a little bit of a dated slide. I don't think it's changed much. So if we look at kids under 5 years of age, so once again, what are the things that actually hurt kids? They limit their activities. Well, developmental problems, so speech and language disorders, mental retardation, other emotional or behavioral disorders, attention deficit hyperactivity disorder, and learning disabilities. Childhood is remarkably spared the curse of death. But the kind of suffering that children have primarily is in the areas of development and well-being, psychological well-being. So I didn't make these data up. And if you look, you have these, this beautiful, of course, you're going to identify the kids who have delayed speech early on. Asthma, of course, it's going to rear its ugly head early, and it's going to stay fairly stable throughout childhood. That's the second bar. But then you look at like ADD and then other emotional disorders, and here we start to see the climb in the early school age years of both ADHD, of course, learning disabilities, ADHD, and then other emotional disorders. And that continues throughout the early portion of the life cycle. Just to reflect on this, when you look at what percent or how many visits to a pediatrician are for stimulant drugs, once again, just thinking about ADHD as an example. And these are index years 1994, 98, 96, 97 to 98, and then 2000, 2002. We see this steady increase overall in the use of of stimulant medicines for attention deficit hyperactivity disorder. Well, lo and behold, look at what's happening with antidepressant prescriptions in the United States over the same index period. We're talking about 4 to 8% of the visits, actually 6% if you follow the line over, of those visits per 100 that are related to antidepressant prescriptive practice. So why are we seeing this? We've become more sensitized as a profession, as professionals dealing with kids, that we know that kids go through normal phases in their life where they may be irritable, but in fact we've become much better at identifying those kids who aren't in fact in a temporary phase. We can identify kids who become much more withdrawn, begin to not enjoy the activities that normally brought them a great deal of joy, and also begin to underachieve academically. It's not uncommon to have a teacher call a parent and say, you know, your kid isn't acting just, isn't quite right. This isn't the kid I knew at the beginning of the year. And certainly, whenever you get that message, it really does, it's a very important thing to not ignore it, because untreated depression can have significant and long-term consequences. And once again, I can't say this enough, it's not just on the self-esteem and psychological well-being of the child, but in fact we know that over the long haul, depression can actually impair the growth and development of the brain. There was one other thing I wanted to say with this. I always laugh at this last bullet. I know I put it in, so I'm responsible for it, but I don't know, since I've moved to the Pacific Northwest, it's always been a joke to me. How many of you have easy access to a child psychiatrist, or even a psychiatrist who knows something about kids? In addition to the fact that we're identifying more and more kids with emotional disorders, we also have not had enough recruitment into child and adolescent psychiatry. And so as a nation, we're facing an absolute deficit in the number of professionals who are available to take care of these kids. I think that this is a struggle for all of us. It certainly is a struggle in my role on the inpatient residential unit to try to create opportunities for outreach and kind of extend some of the information that I know to primary care docs who are suddenly caught in this gap of having to treat kids with medicines that they might not feel comfortable about. So I think this will be a struggle that we'll all have, but I don't want this struggle to be a reason to not make the referral. I can't say that enough. Depression is pretty heterogeneous in terms of the spheres that it can, the spheres of activity that it can affect. But generally, these are individuals who actually acknowledge that they feel sad. And usually kids from the age of 7 on are pretty good reporters of how they feel inside. One of my favorite things to tell kids when I'm talking to them, for instance, is that, you're the world's expert on what's going on in here. No one can see that. And until you ask them, I've had many a situation where I've interviewed kids in front of their parents and elicited a very, very significant history of imminent suicidality that their parents were totally unaware of. So it's important to ask. Kids can tell you. They're as accurate as anybody, and more accurate than anybody. And in fact, you will find in many cases that kids are harboring rather profound senses of guilt and sadness that really affect their optimism at a time in their life when we think the world is their oyster. We think that. They don't. I've often used grades as a real nice, soft indicator of whether, in fact, there is evidence of a depressive illness, mainly because academic underachievement is a very early sign that, especially in a kid who's previously a high-functioning kid, or even a kid who's functioning in the average range and suddenly is no longer functioning that way. Obviously, in the teenage years, we start getting into sex, drugs, and rock and roll. And in fact, sexual activity can go both ways in mood disorders. Sometimes promiscuity is an attempt to hide the feelings of depression. Sometimes it's done in the service of the manic episode that the kid is struggling with. But adolescence being a time of experimentation, they often will experiment as well with things they shouldn't experiment with, and drug and alcohol abuse is a very common problem. So the kids are the experts on sadness, they're the experts on guilt, they're the experts on hopelessness. And interestingly, it's not unusual for kids to complain about sleep, but whenever it's been studied objectively, you usually don't get any objective evidence of a characteristic sleep disorder in kids with depression. And I'll talk about that in a little bit. Suicide is huge. Suicide is the third leading cause of death in young people, followed with number 1, accidents, number 2, homicides. So your ADHD kids get killed by accidents, your depressed kids commit suicide. And that's been the association in my mind throughout my career. These are the mental disorders that confer increased risk for the biggest killers of our young people. We'll go through the holy trinity of depression. So the holy trinity of depression is anhedonia. So think of hedonism. Well, this is lack of hedonism. It's a pervasive and persistent sense of not being interested in just about anything that once brought you pleasure. And it has to occur over a 2-year period, according to the DSM criteria. It's frequently accompanied by sadness and guilt, and things that once were fun are no longer fun. As I mentioned, sometimes to avoid the numbness, kids will engage in some high-intensity activities to try to avoid that sense of anhedonia, but it's clearly not effective, not a sustained way of treating depression. Anergia, loss of energy, the second leg of the stool. Declining academic performance and difficulty concentrating clearly are manifestations of a loss of energy. And in fact, kids who once were quite good at following up with their responsibilities no longer are doing that as well. So not just homework, but also their own self-care as well as the chores that they're responsible for. Sleep disturbances are frequently reported by kids and by young adults as well. Even though we see there's a developmental transformation that occurs in sleep throughout from early pre-pubertal years all the way through and including young adulthood. So, so because, if you will, sleep architecture is a moving target, it's not easy to identify objectively those changes that the kids will talk about. But it is unusual for kids to say that the parents may think that they sleep a lot or they don't have enough energy, they're always in bed, they're hard to get up. When you sit down and talk to them, well, what time do you go to bed? 8 o'clock. What time do you fall asleep? Midnight. So to me, that's a 4-hour sleep latency. Anytime your sleep latency is longer than 30 minutes, you should be thinking, what's going on here? After you fall asleep, do you stay sleeping till the morning? No. Sleep continuity disturbance is another characteristic finding that kids will report. And then finally, early morning awakening is common, but you do get kids who, in fact, can tell you that even though they may wake up early in the morning, they just don't get out of bed for a long time, and they just lay there because they don't have energy. Mornings are usually horrible for a kid with depression. Appetite goes in 2 directions. Kids can increase their appetite or increase their food intake and gain weight or lose weight as well. Usually what you see is a change in their diet. Kids will gravitate toward, if you will, high gustatory intensity foods. So foods with lots of salt, sugar, and they'll stop eating the raw broccoli. Typically, the libido is decreased. Now, you tend to not think of libido in young, very young kids, but certainly in teenagers you do, and certainly in young adults you do. And typically in depression, the libido, the interest in members of not necessarily just the opposite sex, but just an interest in things sexual are decreased. So let's talk about what objectively, in fact, the characteristic finding that used to be talked about with major depression in adults was that they had a shortened REM latency. Now, all that means is the period of time from when you actually fall asleep to the first episode of having dreams is usually about 90 minutes, between 90 and 120 minutes. In individuals with depression, it's usually 60 minutes or less. If you have sleep onset REM, that's called narcolepsy. So, if you think about that variable a little bit, kids with depression do not have shortened REM latencies when they're depressed. But after you treat them and they're in remission, lo and behold, you can find that their REM latencies differentiate them from non-depressed control kids. Dexamethasone suppression, we used to use a drug called dexamethasone to look at cortisol. The cortisol is the hormone produced by the adrenal gland. It's mobilized by the adrenal gland during periods of chronic stress. Normally you see people, adults with depression, having very high basal levels of cortisol. And in fact, when it comes to when they're actually dealt with the stress, their cortisol bursts tend to be a little blunted. So they have big adrenal glands, they're churning out a lot of cortisol, and then when you give them a drug that's a high potency steroid that should turn off the pituitary from driving the adrenal gland, they still turn it out. In other words, they're called non-suppressors to dexamethasone. So we used this test back in the 70s and 80s to try to see if this was a biological marker of depression. And it turned out it wasn't a very sensitive way of identifying people with depression. It didn't have enough sensitivity or specificity to be used as a diagnostic test. But when it was studied in kids, even the kids who were dexamethasone non-suppressors, once they were in remission, continued to be dexamethasone non-suppressors. So some people argue this is the mechanism by which depression stays alive if you don't treat it adequately long term. Okay? So in other words, the follow-ups of the kids in remission in the old studies were seen 2 months after remission. It takes 6 months to a year to adequately treat an individual with an episode of depression with a full course of cognitive psychotherapy. And usually, when I talk to parents of kids, I'm talking about you need to devote 6 months to a year to taking care of this problem. You can say that to young adults as well. The same holds true. The studies have been done both in adults as well as in kids to show the benefits of a full course of psychotherapy to prevent exacerbation of the index episode and also to prevent future episodes. So it's probably why we saw a lot of dexamethasone non-suppression. They were still churning out a lot of cortisol. And interestingly, when you look at the adrenal glands of individuals who've had chronic depression, they become hypertrophic or they're enlarged. In young people, psychosocial stressors correlate better with mood symptoms. So the problem that we all used to run into was, well, gee, no wonder this kid's depressed. Look at this and this and this that's going on in their life. Well, that's not a reason to not treat. And I can't say that enough. Just because we understand that the loss of a parent would be a source of grief for an individual, there's no reason to sit back and ignore it. Because essentially, physiologically, that individual is going through a biological change that's then going to prime the body for that response to lower and lower thresholds of stress. So we want to undo that training, that physiologic training, that brain training. What's kept us from actually seeing the benefits, I think, of antidepressant medicines and other medicines, not just antidepressants, but medicines that have antidepressant properties in kids, is that given the fact that these kids tend to be much more coupled to their psychosocial circumstances, it's not uncommon for them to have higher rates of placebo response. And in most of the drug trials that have been done in young people, placebo response rates have been as high as 30%. So for any chemical to show that it's better than placebo, it's got to beat it by, you got to have a 70 or 80% response rate. And we know that that's a hard thing to do. It's a huge confound in many of the trials. So, of course, I do have to spend a little bit of time talking about the Food and Drug Administration because they have been. It's been interesting. I've actually, when I was working in the pharmaceutical industry, I had many, and I have to say wonderful. I wouldn't call them wonderful at the time. Experiences with people in the Food and Drug Administration. At the time, I was on the other side of the table, so that's why I couldn't call it wonderful. But I can say that this is an agency, this is, from my perspective, the best tax dollar that you spend. These are the people who protect us from snake oil. And they're a very, very rigorous and scientifically attentive organization. They take to heart this issue of protecting the American public from being exposed to things that aren't, if you will, effective for particular conditions, and they also tend to be very conservative in terms of how they interpret the data. So, in some ways, you could say they're kind of like a guard dog for the American public. But the downside of it is that you have to go in there with an awful lot. Their designs are sometimes they sometimes set standards that really were not feasible. And there have been times in the history of drug development in the United States where some of the stances that they've taken have actually impeded the testing of medicines in young people. I think that's changed substantially now. Well, one of the things that happens, now you've got to understand that the United States Food and Drug Administration talks to the other drug administrations all around the world. So they talk to the people at in Canada and England, all of the agencies that regulate the approval of drugs to be marketed to the public or for various medical conditions. It turned out that there was an antidepressant trial that kind of hit the radar screen in England. In teenagers who were being given an antidepressant, where the teenagers were having an increased flurry of suicidality. And I'll define that a little bit later. But there was increased, what's called an adverse event rate for kids who are in the assigned to active, not placebo treatment. The FDA looked at the data from that trial that was shared with them. They then went back and looked at the drug trials that were registered in their own database. And lo and behold, they felt that maybe there was a signal there. Signal meaning, hey, we have something to worry about. We have to protect the American public. And especially young people being given these medicines. So they essentially established or asked all the drug companies that had antidepressants on the market at the time to put a black box warning. So that's a big thing. It's a big to-do if you happen to be a pharmaceutical company, because that means, and if you happen to be a physician prescribing that drug, it is a warning to be careful about the use of that agent. And so, and in fact, none of the antidepressants were excluded. Oops. The public warning came in October of 2004. The black box warning was in the labels in 2005. And in December of 2006, the FDA's Psychopharmacologic Drug Advisory Committee, they agreed that labeling changes were needed to inform prescribers about this increased risk of suicidality in young people. Now, the interesting thing is that when they went back and looked at their trials, what they found was the suicidality, and I think this is really important. It wasn't limited to the, children and adolescents. They found increased suicidality in young adults up to the age of 24. Now, of course, this makes perfect sense to those of us who kind of know that the brain is continuing to be very, very highly remodeled throughout this whole period, so that we really don't have, if you will, a stable brain. And those of you who remember your childhood know this, until well into our 20s. And because it's undergoing a huge amount of remodeling, with neurons being made, pathways being laid down, pathways then being retracted, white matter being generated. The brain is an enormously dynamic organ. And so, as you would expect, any attempt to intervene in that organ with a pharmacologic intervention may have some unpredictable consequences. So they saw suicidality in people up to the age of 24 years. It always occurred within the first 2 months of treatment. And so, and in fact, older than 24, they didn't see it. And the one thing that they did know was that, in fact, when you looked at suicide rates among people 65 and older, if they were on antidepressants, they had a markedly mitigated suicide risk. So they knew, the FDA acknowledged, that, in fact, depression is a terrible disease, that it accounts for most of the suicide in the United States, although there are other, or lots of the suicide, or at least half of it. But they also realized that, gee, maybe we had a treatment that was contributing to, at least initially, to some increase in suicidality. And so they set out to warn the American public. They initially put that black box warning on all these drugs, and now you will see on any drug that gets approved for some treatment of depression, whether they've had increased suicidality or not in their pivotal trials, the warning goes on those drugs. So that these are all characteristically antidepressants, but you'll see it on drugs like Lamictal, for instance, lamotrigine, which is an antidepressant, or it's an anti-epileptic drug now approved for bipolar depression. You'll see it on even aripiprazole and other agents. So, obviously, what do you want to do when you're faced with this problem? And to me, the best thing, whenever you have someone sitting in your office, the best thing to do is educate. They have a new illness, new disorder. You're going to want to educate them about the nature of the disorder and the nature of the treatment. You want to make sure you talk not just about the antidepressants or other drugs, but you want to look at all the treatment choices and keep in mind, that if you do have a kid in your office, you want to stay close to the clinical evidence, because not all the antidepressants have actually been tested in kids. The FDA recommended that you schedule more frequent follow-up visits during the first 2 months of treatment. Usually it was, okay, see them every week, maybe every 2 weeks, make sure you're available by phone, emphasize your availability between visits, and then highlight the need to report new or sudden changes in behavior, especially in mood or other feeling states. This is what they meant when they talked about suicidality. Suicidality means increased thoughts about suicide or dying, not just attempts to commit suicide. New or worse depression, new or worse anxiety, new or worse agitation, panic attacks, because these do seem to provoke some of these increased thoughts. And then a change in the sleep pattern, irritability, aggressiveness, and impulsivity. Now, there does seem to be, and I'll talk about bipolar disorder subsequent to this, but there does seem to be a tendency of early onset depression to be associated with later bipolarity. So, and I'll show you some of that data. The other thing, now, one of the terrible things that happened after the FDA published its warning is that all the primary care physicians who in fact had been treating 70 to 80% of individuals with depression at that time started pulling the kids off antidepressants. And the problem with that is that antidepressants actually can have withdrawal syndromes associated with them when you stop them suddenly. And in fact, that the illness can sometimes be more of a problem for suicidal behavior than the increased irritability and thinking about suicide. So what we saw in the United States in young people was that for a decade, since the advent or the prescribing of antidepressants to young people had started, we saw for the first time in probably 30 years that the suicide rate was decreasing in young people. And then the FDA came out with its warning, and for the next 3 years, the rate climbed again. So, and of course, now I think with their recommendations around monitoring, even though many primary care physicians are a little bit more, are still very apprehensive about prescribing antidepressants, they still will do it now that kind of the dust has settled from this. You know, I talk about this because I think it's a, you know, it's a very, it's an interesting story, number one, and number two, it kind of tells you, shows you a little bit about the complexities between what the Food and Drug Administration does, how our primary care docs have to respond, and then, you know, we're still left with a problem, and the problem is effectively treating mood disorders in kids. As I mentioned, depression is the most serious, is the most important cause of suicidal thoughts and actions. Some people have a particularly high risk suicidal thoughts or actions, and of course these include mostly people with a family history of bipolar illness, or in fact sometimes we see that suicidality does run in families. So it's important to elicit that. So let's move on to bipolar disorder. Bipolar disorder, you could just say bipolar disorder in the old days. Now there are about 6 subtypes of bipolar disorder. So you have your bipolar 1s, your bipolar 2s, your cyclothymic disorder, your bipolar not otherwise specified, et cetera, et cetera. But they're all out there. And essentially bipolar disorder is, in the old days, the modal disorder around which bipolar was described was manic depressive illness. Once again, a medical condition that causes extreme changes in mood between depression and periods of mania, or in other words, euphoria. In between the episodes of either highs or lows, in classical manic depressive illness, you can have normal mood. So that this was viewed as an episodic disorder that had 2 poles, or 2 areas of severe dysfunction. One up, one down, just in terms of the sense of well-being that occurred. Frequently in the classical illness described by Kraepelin in the early, almost 2 centuries ago, it was a form of madness that did not have any obvious precipitant, could be associated with psychotic illness, and was described, and then these individuals kind of recovered after a period of extremes in either being too high or too low in their moods. Now, we know once you have the classic description and you characterize the syndrome, that frees you up to start looking in the population at large for evidence that there are other forms of the illness. And what you find is really only half of the individuals with well-diagnosed bipolar disorder have psychotic symptoms. Most just have the mood disorders. No, almost most, evenly, will have the mood disorder without hallucinations, delusions, and other impairments in reality testing. Now, the thing that I always found so intriguing is that, if you stop and think of what I just told you, well, you have to have the high, you have to have a period of normal function, you have to have the low. And this could take years. It could take years to diagnose bipolar disorder because you'd have to wait for both poles to rear their ugly heads. Well, fortunately, we had very informed ancestors in psychiatry who said, no, as soon as you have 1 or more manic episodes, you got it. Okay? Now, the problem is, most bipolar disorder starts with depression. And so there's the rub. And if you look at young people with depression, somewhere between, and this has been replicated across 3 studies now, somewhere between 30% and 50% of young people with depression go on to have classical bipolar illness. Okay?
Say that again.
30 to 50%. Okay? The earlier the onset, the more likely the subsequent bipolarity, especially if you have suicidality and psychotic symptoms accompanying the mood disorder. So let's walk through. What's mania look like? Or what's it feel like? It actually feels better than it looks, but I just had an interview today with a young man who I said, have you ever felt so happy that people thought you were drunk, even though you weren't? And that's exactly they will endorse that out the yin yang. I can't tell you how many times my folks thought I was drinking and I wasn't, and would laugh at things that were inappropriate. Aunt Martha died. Oh no. And it truly is that dramatic. You have individuals who really feel happy, feel euphoric in the face of pretty devastating psychosocial circumstances. Most commonly in young people, though, we don't get the happy, we get irritable. And we're not talking about normal irritable. We're talking about, bite your head off irritable. Thinking very highly of yourself, we call that grandiosity, having an inflated self-esteem, not needing as much sleep as usual, feeling rested after as little as 3 hours sleep. Once again, there are developmental limits to this. Usually my cutoff with a teenager is less than 6 hours of sleep. I start to think mania or mixed state, because teenagers need 8 to 12 hours of sleep normally. And then talking more than usual. Being more active than usual, having difficulty concentrating due to having too many thoughts at once. We call it racing thoughts. In the worst case scenario, racing thoughts turn into what we call flight of ideas. So the thought doesn't, even though there's an association of one thought to the next thought, it kind of goes off somewhere. And within minutes you're off and talking about coffee prices in Bulgaria. Being easily distracted by sights and sounds and acting impulsively and doing reckless things. So, in any kid, a young person, where they will frequently talk about buying things they don't need, driving recklessly, and getting in. And of course, older adults get into foolish business ventures. But in fact, you'd be surprised at how many times kids will actually spend money to the point of, even though they don't have a lot of disposable income, they still manage to do this. And of course, frequent and indiscriminate or unsafe sexual practices. The changes in mood are frequently accompanied by symptoms of anxiety as well. And so it's not uncommon for the individual who really has bipolar disorder, if you have years to see them back again, to have panic disorder. And the real problem with that, either having general anxiety disorder or panic disorder, the real problem with that is that we tend to treat these with antidepressants. And when you do that with someone who's bipolar disorder, you've created a rapid cycling mood disorder. So the antidepressants can be deadly to the individual who has bipolar disorder. Okay. Substance abuse is common, more often, of course, like all bad things, more often in men than in women. And in fact, it really screws up my work, because if they're picking their drugs and I'm picking my drugs, their drugs win. And alcohol really actually can make the brain more treatment resistant, because it's depleting all of those wonderful biochemicals like serotonin that help you with recovery. Obviously, differential diagnosis, I have to say something about this. I actually, for the first time in 30 years of practice, I actually found a kid who had thyroid disease. it was a real pleasure to be able to call up their pediatrician and say, "Got one," you know. And luckily, I didn't start that kid on medicines because I waited for the labs to come back. But after 30 years, you kind of get tired of waiting. I have seen some young adults with very, very severe multiple sclerosis that presented with mania. I have seen some individuals with neoplastic process, cancers present with bipolar disorder. So I mean, these are not. You really do have to be attentive to the medical workup in an individual with mania. And it's not unusual for mania to actually look like delirium at times. Now, the other interesting thing that we encounter in young people as well are the use of steroids. We're starting to see that more and more in young people. We thought we had an epidemic of that at one point earlier this summer. I don't think that ever was borne out, but kids do gravitate to an illicit steroid market, as well as to the meth market, as well as to the cocaine market, and it's clearly in the differential. I forgot to mention, all of our wonderful energy drinks that cause kids to get wired, and then they get sleep deprived, and then when they're up with their friends, they might engage in other substances. It actually can precipitate a manic episode over time. So it's important to wash those things out and make sure you're dealing with someone who, comes by their mania honestly. Okay? So let's talk about the epidemiology of this illness. I mean, it's bipolar disorder has a relatively flat point prevalence in both in adolescents as well as young people and older people, essentially ranging between 0.4 and 0.8%. But 1 person in 5 with bipolar disorder has early onset. So what that means is that their symptoms began in their teenage years. That's what we call early onset. It's defined as the age of onset before 18. And of course, this is even more alarming if you get a well-diagnosed population of adults with bipolar disorder. And you then do your backward dissection of when did you have your first mood symptoms. Almost 0.5% had their first mood episode prior to 10 years of age. Now, I've talked with some of the thought leaders in this area, people who've really been working with doing research in bipolar disorder for decades now, and some of them had a certain degree of confidence that they could actually see bipolar symptoms in preschoolers. Now, I certainly don't have. I get my back up about my 2- and 3-year-olds where that gets raised as a possibility. But whenever you have a well-characterized pedigree where both parents have bipolar disorder and are on lithium, and they have a kid with a sleep disorder, after you're sure that the parents have stable mood, you're left with this nagging thing. And of course, I'll try to send those kids to the experts, the experts in that area if I can. But it happens, and it's been described. The more recent estimates, though, suggest that, as I mentioned, the point prevalence of bipolar disorder is the same in kids and adolescents as it is in adults. So this 0.4 to 0.8% clearly is a number you can apply to younger people. As I mentioned, 6 years of age is what now is accepted by the Food and Drug Administration. Well, the Food and Drug Administration accepts 10, as early as 10. You can't enroll a kid in a bipolar trial who's younger than 10. And that's a step for them because when it comes to schizophrenia, they won't accept a kid below 13. But age influences symptom expression. If you get true bipolarity in a kid so that it's not the first episode of depression, what that kid is going to look like is an ADHD kid on steroids. Very simply, they've got much more irritability, much more explosive outbursts, much less sleep, and much more activity than they normally have when their ADHD is well controlled. So affective storms is what the term is. It's used, but it's explosive aggression and violence. They don't feel good. They have a lot of energy. They move around a lot, but they sure don't feel good. There's no joie de vivre. And the mood disorder can be superimposed on other things. And let me just show you this next slide. When you talk about ADHD, as many as 25% of children and adolescents with ADHD in some studies go on to develop bipolar disorder. Now, I think this is a sampling error. Not sampling, it's a referral error, because I think these are studies that come out of tertiary care centers. So this is the Harvard group that follows kids with ADHD. They're only going to get the treatment-resistant kids in the first place. So I don't think it's nearly that in a typical primary care practice. But ADHD confers risk for subsequent bipolarity. Conversely, if you took well-diagnosed bipolar adolescents and didn't backtrack, 60 to 90% of them will have met criteria for ADHD. So we do know that there is this kind of interaction between ADHD and bipolar disorder. And the earlier the age of onset of the ADHD, the increased risk for subsequent mania. The difference is, of course, even though they have a lot of shared clinical features with distractibility, hyperactivity, and talkativeness, it's a sleep disorder that really differentiates them. Conduct disorders, likewise, 40 to 70% in some studies. Bipolar kids will have conduct disorder. Major depressive episode, 20 to 30% of children with major depression develop bipolar disorder. Actually, Geller had a follow-up study that went up to 50%. Substance abuse disorders. I want to get through this because I do want to talk a little bit about treatment. Obviously, what we're left with in the treatment of bipolar disorder are mood stabilizers for the mania and mixed state and antidepressants for the depressed phase. Obviously, antidepressants can worsen mania, so we now have some approved treatments for bipolar disorder in young people. And there have been more than 400 case reports and series regarding lithium, divalproate, olanzapine, and risperidone. And these are some of those studies. I'll just go through these very quickly and get to the bottom line, which is when you look at these overall case series, 50 to 60% of people, young people, respond to lithium, which works very well for acute mania in adults. Whereas anti-epileptic drugs, you push the envelope up to 80%, and then atypical antipsychotics also up to 80%. So these are very, very powerful. The new second-generation antipsychotic agents are really very, very powerful, and certainly more powerful than lithium in creating mood stability in young people. And in fact, when you look at the nuisance factors related with lithium, you really are, you have a much more benign, you have an opportunity to go with a benign drug there. You don't have to monitor renal function, thyroid function, and serum concentrations. So I think these have now supplanted lithium in terms of first line of treatment. I want to say one last word about suicide. It's the 13th leading cause of death in the United States. Worldwide, the 11th in the United States, and the 3rd among U.S. residents between 10 and 24 years of age. Suicide attempts that result in non-fatal injuries take a heavy toll on not just the people themselves who do this, but more often and more terribly, the people left behind. If you talk to anybody who's a parent knows, you never go into parenthood thinking that you're going to outlive your kids, and that can have a lifetime impact on the survivors. When you think about what this means for our emergency departments, over almost 125,000 visits to the United States emergency departments were because of attempted suicides or other self-harming incidents in persons aged 10 to 24 years of age. So this is what's happened. I think these are the data I wanted to show you. Annual suicide rates really dropped up until 2001. And I think I mentioned that the FDA came out with its warning in 2004, where they climbed then for the next 3 years. But we were making some real inroads in terms of overall suicide rates in the United States. So, just to summarize, mood disorders can occur early in life. age appears to affect the clinical presentation and the response to treatment. We have lots of clinical trials that are currently being conducted to get approval for more agents in young people. We know that they behave differently in their response to psychotropics, but that these are highly effective agents. They give us a new tool in our toolbox. And at the same time, we're learning much more about the psychosocial therapies that are available to for treatment of these individuals, and early effective intervention, both with medicines and psychosocial therapies, are the way to beat this illness. So I'll stop there and take questions, and thank you all for your patience.